section in OSA. I also request Dr. Davis, Professor, Department of ENT at Al-Azhar Medical College and Super Specialty Hospital, to kindly chair the session.
Dr. Renuka Balu is a Clinical Associate Professor in the Department of ENT Head and Neck Surgery at the Amrita School of Medicine in Kochi. Her specialized area of interest lies in snoring and sleep apnea surgery, where she leverages her robust academic background. Dr. Renuka is a well-known figure in various state and national conferences focused on sleep apnea, actively contributing to the scientific community. Over to you, ma'am.
So good morning. I thank the organizers of SnoozeCon 2025 for inviting me for this talk. So, what is obstructive sleep apnea? Obstructive sleep apnea is characterized by repetitive, partial or complete collapse of the upper airway during sleep, resulting in disruption of normal sleep architecture, and it is usually associated with arterial desaturation. If these respiratory events occur for more than 5 times per hour of sleep and are associated with symptoms most commonly snoring, excessive daytime fatigue, and witnessed apneas, we call it as obstructive sleep apnea hypopnea syndrome. And in the age group of 30 to 35 years, around 20% men and 5% snore, which increases with age. Obstructive sleep apnea and upper airway resistance syndrome. You cannot hear. So obstructive sleep apnea and upper airway resistance syndrome, they represent the two distinct but related entities in the spectrum of sleep disordered breathing. Upper airway resistance syndrome is defined as the occurrence of excessive daytime sleepiness unexplained by any cause and associated with more than 50% of respiratory events that are non-apneic and non-hypopneic. So the RARAS, which is otherwise called as respiratory effort related arousals, that means it is characterized by progressive increase in the respiratory effort. So the first step in the management is to recognize the presence or absence of OSA. If present, the next step is to recognize the severity. So a thorough history with participation by the bed partner if possible and physical examination are integral to the initial evaluation. And the diagnostic accuracy can be improved by identifying the constellation of symptoms and also with flexible scopy. Overnight polysomnography remains the gold standard in the initial diagnosis and the only means of distinguish between OSA and upper airway resistance syndrome. Each method has got its own advantages and disadvantages. So coming to nocturnal symptoms, even the snoring is the most frequently reported symptom in OSA and is found in around 70 to 95% of patients. The snoring may have been present for many years and increased with intensity over time and is exacerbated by weight gain, alcohol consumption, sedative medication, sleeping in supine position. So the characteristic pattern is one of the loud snores or brief gasps with 20 to 30-second period of silence. Even though snoring is so common, it is a poor predictor of OSA. So witnessed apneas are observed up to around 75% of the bed partners and is the second most common nocturnal symptom. Nocturnal dyspnea episodes typically occur with arousal and are associated with feelings of panic and anxiety and generally subsides within a few seconds. So while the nocturnal symptoms are more specific and the common daytime symptoms like this excessive daytime sleepiness, they are all less specific as they can result from any other abnormal sleep disorders. So excessive daytime sleepiness is the most common daytime complaint. An inappropriate urge to sleep, particularly during relaxing, sedentary activities and during meetings, active conversations. Morning or nocturnal headaches are typically dull and generalized and may require analgesics. Decreased vigilance is also mainly because of sleep fragmentation, which can lead to diminished memory. And in women, it can present as insomnia, anxiety, and fibromyalgia. When age increases, there is increased airway resistance, increased parapharyngeal fat, and decreased muscle reflexes that are important to maintain the upper airway patency. Men tend to have the fat in the upper body, including the neck, leading to airway collapse compared with the females, but later on after menopause, less estrogen and progesterone will cause changes in the body fat distribution and desynchrony leading to the upper airway obstruction. So fluctuation in weight gain has been demonstrated to influence the severity of OSA. So history should also include the coronary artery disease, stroke, diabetes, and dyslipidemia, as OSA is associated with the activation of thrombotic pathways and increased inflammation leading to cardiovascular disease. A positive history on screening should mandate a comprehensive physical and local examination. So there are many available questionnaires like Epworth Sleepiness Scale, Stop Bank Questionnaire, Berlin, and Stanford Questionnaire. The most commonly we used is the Epworth Sleepiness Scale, which quantifies sleepiness in everyday activities using an 8-item scale ranging scored from 0 to 3. So the ESS score ranges from 0 to 24 with higher scores indicating more sleepiness. Stop Bank Questionnaire. If yes for more than or equal to 3 questions, which indicates a high risk of for OSA, more than equal to 5 is more predictive for clinically relevant moderate to severe OSA. So blood pressure should always be recorded, as both hypertension and hypotension has been found in patients with sleep disordered breathing. Obesity is associated with OSA and assessed by the measurement of body mass index. That is, we calculate the height and weight and body mass index in kilogram per meter square. So neck circumference should routinely be done with the neck circumference should be done at the superior border of the cricothyroid membrane with the patient's head in the upright position. Neck circumference of more than 40 centimeters in female and more than 43 in males is a positive predictor for OSA. Measure the cricomental space and the thyromental angle. As the neck enlarges due to adiposity, the cricomental space and the thyromental distance shorten. If it is more than ideally it should be more than 1.5 centimeters. Retrognathia is the result of delayed growth of the mandible, maxilla, or both, and is associated with the posterior displacement of the tongue. We should always look for the malocclusion of the teeth, and overjet is defined by the greater more than 3 millimeter anteroposterior distance between the upper and the lower incisors. Always we should palpate for TMJ click, that is temporomandibular joint click, as there is greater risk for airway collapse in supine patient due to the posterior displacement during sleep. So the hyoid bone should always be palpated because it is very important for several functions, including the maintaining of the airway. The displacement is accompanied by the inferior displacement of the tongue into hypopharyngeal area. So after taking the proper history and physical examination, we should go for the local examination. Anterior rhinoscopy and along with the 0 degree rigid endoscope is done to perform the to look for any deviated nasal septum, hypertrophy, turbinate, nasal polyps, which can be the cause of snoring and OSA. Also, nasopharynx should be examined for any adenoid and any prominent salpingopharyngeal fold. Examination of oropharynx is to check for the presence of any oropharyngeal narrowing. The classification that is widely used is the Friedman's classification. This is modified again in 2017. Developed a clinical 4 degrees clinical staging system incorporating the tonsil size, position of the soft palate, and the tongue size. The anatomical staging system predicts the success rate better than the OSA severity. Examination of hypopharynx and larynx with 70 degree scope should look for any pathology. Next is fiber optic nasopharyngoscopy. Fiber optic airway examination is conducted to identify the level of obstruction. Muller's maneuver, which is the forced voluntary aspiration with mouth and nose closed, is performed. So this procedure is done in awake patient in semi-upright position. Nasal cavity is anesthetized with cotton pledgets dipped in 4% xylocaine. Flexible scope is passed to look for any deviated nasal septum, turbinate, hypertrophy, polyps. Scope is now advanced from the nasal cavity to the nasopharynx. Any pathology should be looked for, and Muller's maneuver is performed to check for any collapse. That is retropalatal. Either it can be circumferential, anteroposterior, or lateral collapse. Scope is Once we note that, the scope is then advanced to check the base of tongue. Patient is asked to take deep breath and then exhale and then hold the breath in expiration for 10 seconds. At the end of expiration, tongue position is visualized and airway space is assessed. Scope is again advanced to visualize the larynx, so the shape of the epiglottis, supraglottis and vocal cords is also noted. Isolated obstruction we can see only in 15%, or more than 85% it will be multi-level obstruction. So lingual tonsil grade is most easily evaluated next as a possible cause of retroglossal obstruction with the tongue relaxed and also then it is protruded. Like grade 0, it is absence of lymphoid tissue. Grade 4 is lymphoid tissue of about 1 centimeter or more in thickness rising above the tip of the epiglottis. So the major muscles that create the form and the shape of the palate is tensor villi palatini and its aponeurosis, levator villi palatini, palatoglossus, palatopharyngeus, superior constrictor and salpingopharyngeus. So anatomically, the soft palate has both a proximal and distal segments separated by what is called as the genu. The anatomical genu approximates the border between muscular and aponeurotic segments of the palate. So the proximal palatal segment has a variable angle from the hard palate, which is called the alpha angle. This is very important because these three phenotypes described based on these 3 points are very important too, because the phenotypic patterns based on endoscopy, like either it can be oblique, intermediate and vertical, it provides information on the shape and the configuration of the airway. In individual with oblique and intermediate, the angle is less acutely downward, and in vertical phenotypes, palatal phenotypes, it is more acutely downward and parallel to the posterior pharyngeal wall. This understanding is necessary when we plan to do palatal surgeries. Polysomnography is the primary tool, gold standard for diagnosing the sleep disordered breathing and other sleep disorders. It can be done as an initial diagnostic study, an interventional study, or as a follow-up study after treatment. There are 4 types are there. Type 1 is the technician attended in laboratory polysomnography and other 3 are portable. Type 2 is comprehensive. Type 3 is cardiorespiratory sleep study and type 4 is a continuous single recording such as ambulatory overnight study. There we can plan for split night polysomnographies followed by CPAP titration on the same night are considered acceptable if the apnea-hypopnea index is at least 40 events per hour of sleep, which is recorded in 2 hours, and then we can plan for CPAP titration. According to the sleep study, polysomnography, we can plan it, we can divide into mild, moderate or severe depending on the apnea-hypopnea index. If it is mild, it is 5 to 15, moderate 15 to 30 and more severe, it is 30. So polysomnography itself is a separate topic, and just a short this thing, like in obstructive sleep apnea, AHI is increased and RERA may be increased, but in upper airway resistance syndrome, it is AHI is normal and RERA is increased. So another method of home sleep apnea testing is watchpad device. There is a recent up-to-date has come, like home sleep apnea testing in adults, which is revised in May 2025. This is a very vast chapter is given in that. So in that it is given like watchpad device, it is there. It is automated algorithm to detect breathing events. Another novel device applies machine learning to mandibular movement analysis. This watchpad test, it has been validated, but alone is not specific for diagnosis. X-ray cephalometry. Before the radiograph is taken, a thin layer of barium sulfate was applied and the X-ray is taken. To standardize the hyoid position, radiographs were exposed at the end of expiration in the natural head position with the teeth in light occlusion. Lateral cephalometry is a 2-dimensional investigation. This is a study done in our department. published in International Journal of Otolaryngology. We analyzed the comparison of lateral cephalometry with flexible scopy, compared the AHI of patients with mild, moderate, and severe. Conclusion was they both are excellent screening tool for the snorers. And cone beam CT or CBCT gives a three-dimensional view of airway, and the CT taken analyzed using Dolphin software. CT scanning significantly improves the measurements of cross-sectional area. Fast scanning times and quiet conditions even allows a dynamic assessment of the airway. The ionizing radiation remains problematic. Compared to lateral cephalometry or CT scanning, MRI has got many advantages. It has got excellent soft tissue contrast, three-dimensional assessment of tissue structures, and lack of ionizing radiation. The MRI, even when performed during sleep, can only provide information only for a short duration of time and are limited to supine position. For routine clinical application, the limited availability and cost are the additional limiting factors. Drug-induced sleep endoscopy, otherwise called as DISE. It was introduced a diagnostic algorithm with its highlight being the ability to provide the dynamic visualization of anatomical areas responsible for the generation of noise and obstruction. The advantage of DISE is that upper airway collapse, which is not visible due to the neuromuscular incoordination during the awake state, we can observe it during sleep, and the treatment advised according to the level of obstruction. The most common drugs we choose are propofol, midazolam, and dexmedetomidine, and the depth of the sedation can be assessed with the use of BIS monitoring, which is otherwise called the bispectral index monitoring, which translates the patient's EEG signals into scaled numbers from 0 to 100, where the 0 is complete silence and 100 is fully awake. So DISE is performed after the BIS recording has been remained steady between 65 and 75 for at least 90 seconds. So the DISE findings are recorded according to the 4 anatomical levels: velopharynx, oropharynx, hypopharynx, and larynx. And what classification is used? According to that, either patent, partial, or complete obstruction we have to note. When the lumen is less than 70% of the expiratory status, partial obstruction is defined, and complete obstruction means when the no lumen is seen. Obstruction pattern is classified whether it is circumferential, decreased anteroposterior, decreased lateral diameter types. Position of tongue base is assessed in relation to vallicula and epiglottis. So hypopharynx obstruction identified when lateral pharyngeal walls constrict and cause luminal narrowing at the hypopharyngeal level. So this is another study we published in International Journal of Phonosurgery and Laryngology. What is the usefulness of DISE compared to awake patients? That we have found out that epiglottic collapse is seen mostly in DISE compared to the awake flexible endoscopy. So one word about the interventional DISE, that is, we use the nasopharyngeal tubes, which are soft flexible tubes which are used in airway management. And nasopharyngeal tube is placed through the nasal cavity and nasopharynx into the oropharynx until the tip is just beyond the soft palate. Having the nasopharyngeal tube during DISE is used to separate those patients who will benefit from palatal surgeries or those who need a multi-level approach. So the evaluation includes history, proper history, anthropometric data, clinical examination, polysomnography, fiber optic nasopharyngoscopy with Muller's maneuver and end expiratory tongue position, DISE, which is otherwise called the drug-induced sleep endoscopy, and the dynamic MRI. So the take-home message is diagnostic strategy includes a sleep-oriented history and physical examination, objective testing and education of the patient. Presence or absence of severity of OSA must be determined before initiating the treatment in order to identify those patients at risk of developing complications of sleep apnea, and we have to guide the selection of appropriate treatment. In order to ensure the holistic approach, treatment for the patient, different specialists, especially pulmonologists, neurologists, orthodontists, otolaryngologists, all are required to collaborate and work as a team. Thank you.
Thank you, ma'am. We'll now have a minute for any questions or queries.